I did not think about that. Yeah, and sometimes with autism, their sensory perception is heightened. So sometimes the texture of certain foods, they're unable to tolerate. And so in that instance, if he's not able to, or he's limiting himself, then they have to consider enteral nutrition.
Yeah,
Wow.
she often posts on Facebook when she has to do it. She's like, I'm about to ruin this kid's afternoon. He hates doing it, but it's the only way that they're going to get.
Right. You bring up another interesting point because enteral nutrition can be your sole source of nutrition, or it can supplement your nutrition. So it sounds like for him, it's something that supplements what they can do. So a lot of times our families will think that if they're on enteral nutrition, that is long-term, it's not reversible, and that's the only form of nutrition that they can be on. But you can actually be on enteral nutrition and consume food orally at times. Okay? So it can be the sole source or just a supplemental source of nutrition. What has to work in order for you to use enteral nutrition? Your GI tract, right? It's one of the biggest differences that we'll talk about when we talk about enteral versus parenteral nutrition. The enteral form method utilizes your GI tract, okay? Parenteral nutrition does not utilize your GI tract. It bypasses that and fed directly into your veins. So what do you think are the benefits of using your enteral or your gut?
Short-term treatment, like you just had stomach surgery or something, like ideally you want to go back to trying to eat normal again.
Right. Right. And it maintains that.
Like the ability of like your intestines to like keep things.
Exactly. Exactly. If you don't use a muscle, what happens to it? It atrophies, you lose it, you destroy it, right? So your gut is essentially a muscle, okay? And so when we don't use it, it loses function. So even if we have a patient that can't tolerate or can't take a lot of enteral feeding, sometimes we'll just give them a little bit, because even a little bit will continue to keep the gut functioning, okay? Even just a little bit. So we kind of touched on this, but some of the conditions that may cause for enteral nutrition, the GI disorders that you talked about, someone with specialized needs, and that's kind of what she mentioned with her friend's son who has autism, decubitus ulcers, or those at risk for development of decubitus ulcers. And I just taught this lecture in my assessment class, so just kind of remember that when we talked about decubitus ulcers, we said that the needs are increased, and so those with decubitus ulcers are at risk for being malnourished. But patients who are malnourished are at risk for developing decubitus ulcers. So it works both ways. So enteral nutrition can keep you from getting decubitus ulcers, and it can help with healing them as well. So these are times where you would not feed someone enterally, okay? So as much as possible, if someone's not able to consume food orally, our first choice would be for them to have enteral nutrition, because that's more physiologically normal. We utilize the gut, we keep everything functioning as it should, but that's not always possible. So when patients have bleeding in the GI tract, do you think it's a good idea to utilize the gut then? Probably not, okay? So if there's GI bleeding, then we would not do enteral feeding. We would probably do parenteral, okay? Obstruction or an ileus. Okay, so when we talk about obstruction, this is some kind of blockage within the GI tract. So either it's caused by a tumor, maybe it's just caused by bile within the intestine. Something's obstructing things from flowing through the GI tract. So that makes sense that if there's an obstruction somewhere, you're probably not going to want to feed through the GI tract, right? An ileus. Think of an ileus as like paralysis of the GI tract. If you think back to biology, you have that peristalsis, the movement that pushes the food down. Well, when someone has an ileus, there's no peristalsis. So the food isn't being pushed down as it should be. So if the food's not being pushed down, do we really want to put more food in there? Probably not, okay? So that would be a contraindication to enteral feeding. And just kind of a side note, so when would we see an ileus? Do you guys know? When might you see an ileus, or that paralysis of the GI tract? Yep. So say you had surgery, right? Surgery puts everything to sleep. It's all your nerves to sleep, so you can't feel anything. It also puts the nerves of your GI tract to sleep. So it takes a while for those nerves to wake up after surgery. So if someone has an ileus after anesthesia, that's probably not the time to start feeding or utilizing the GI tract until that resolves. Intractable vomiting or diarrhea. Okay, this implies that it's uncontrollable. There's no other way to say this, okay? So if you're feeding someone through the GI tract and you're kind of having intractable, which means kind of explosive, vomiting and diarrhea, you're probably not going to want to feed through the GI tract, okay? Probably just best to let it rest and figure out what's going on. High output intestinal fistula. So let's talk about what a fistula is. A fistula is an opening that's not supposed to be there, okay? So it's not a normal opening, okay? It's something that's developed either from surgery or from trauma or from cancer. So it's an opening in the body that's not supposed to be there. So an intestinal fistula is an opening that's not part of the normal physiology. It's extra, okay? So if you're feeding into the GI tract and you have this opening that's not supposed to be there, when you feed into the GI tract, all of that you're feeding goes somewhere that it's not supposed to be. So the contents can cause infection wherever it's sitting at or wherever it goes to. So you'll notice that the bullet point says a high output fistula. So that's implying that there's a lot of contents being spilled through that opening, okay? If only small amounts are being spilled, they may try to do enteral feeding, but if it's a high output fistula where lots of volume is being spilt into this extra space, then we probably don't want to feed through the GI tract. Severe pancreatitis. You guys tell me this one. What do we know about pancreatitis? Malabsorption, right? So if it's a very severe case, and you probably don't want to feed through the GI tract because you're not going to be able to release the enzymes necessary for absorption. Okay? So all of these contraindications to enteral feeding are actually reasons that we would choose to feed someone parenterally. Okay? So these are reasons why we would feed them parenterally. These are just examples of nutrition diagnoses that you may use for patients that are on enteral feeding. And it kind of makes sense because oftentimes if someone's malnourished, they're probably going to need some nutrition support, increased energy expenditure, involuntary weight loss, impaired swallowing or dysphagia, biting or chewing difficulty, and impaired nutrient utilization. So just all examples that you might, of PS statements you might see being used for this population. Okay. So when we think of enteral in comparison to parenteral nutrition, some of the benefits include the cost. We don't always want to think about cost, but we do want to be cost conscious when we're working with our patients. The cost of enteral feeding is significantly less than parenteral nutrition. So by all means, enteral nutrition is physiologically better for the patient and it's typically at a lower cost, okay? So one of the things that you'll often hear kind of in the nutrition realm is if the gut works, use it, okay? The gut works, let's use it. It also aids in maintaining gut integrity. That means that it's helping the gut to function. It keeps the muscles functioning so that they don't atrophy. And it reduces the incidence of sepsis. This is a big one. When the gut atrophies, what actually happens is some of the bacteria inside the gut, which is what we call the good bacteria, right? This is our microbiome, our good bacteria. Some of that bacteria inside of the gut can actually leak out into the bloodstream. So it leaks out of the gut because that gut begins to atrophy, the muscles atrophy. So some of that good bacteria inside of there leaks out into the bloodstream. Because that bacteria is not supposed to be there, it can cause an infection or an infection in the bloodstream, which is known as sepsis. So one of the complications or potential complications of enteral feeding is that people can develop sepsis because of that gut atrophy. I won't ask you this term on the exam, but I will tell you it's called bacterial translocation. Bacterial translocation. So the bacteria in the gut translocates. It gets out of the gut into the bloodstream, and that can cause an infection. Bacterial translocation. Okay, so by using enteral nutrition, we reduce the incidence of sepsis. Okay? The disadvantages is the potential difficulty with administration, and this really is relative. Sometimes it's easier, or people think it's easier, just to stick a needle and feed through the vein. Okay, there's a perception that that's easier. Sometimes that makes the family feel better than having to see a family member with a tube in their nose or going in surgery and having a tube placed in their stomach. So when we talk about potential difficulty with administration, that's kind of a relative thing. Sometimes it's just explaining to the family that a tube feeding is reversible. We put the tube down there, but it can come out. It doesn't mean that they can't, feed orally. But sometimes the perception of that for a patient's family is kind of overwhelming versus them having a needle and they're getting fed through the vein. Okay? So sometimes it's just explaining to them the benefits of using enteral nutrition. And sometimes explaining to other healthcare members as well. So for those of you that are going on to be dietitians, one of the big things that we do, if we're seeing a patient and maybe the doctor recommends parenteral nutrition, but you go in and you see the patient and you said, well, the gut's working, so maybe we should consider enteral nutrition. There are ways to say that in an appropriate manner, but we always want to consider enteral first if the gut is working. Okay? And then sometimes there's poor tolerance. So some of our formulas have a higher osmolality, okay, which means they're a little bit more concentrated. So for some patients, once that concentrated substance hits their stomach, it causes them to have GI issues. So some people will have poor tolerance. But usually what we do if a patient presents with poor tolerance, we can adjust the formula for something that they can better tolerate, okay? So even though these are disadvantages that can be overcome. We kind of touched on this. Our tube feedings can be our sole source of nutrition, which means they don't get anything else. They're just getting enteral nutrition, okay? So the formulas are designed to meet 100% of their needs, okay? They meet all the RDAs, all the RDIs, so they're fine if that's all we give them, okay? But in some instances, we use it as a supplement, okay? So think of the patient that maybe has cancer, their GI tract functions normally. During the day, they're able to eat orally as much as they can, but they can't get in quite enough calories. So at nighttime, let's say between 9 at night and 9 in the morning, they feed them enterally. But during the day, they're able to consume food orally. So a lot of times we'll do that because there's a certain satisfaction that patients have with actually chewing food, It's off subject, but I've even seen where some patients who can't swallow, but they'll work with a speech therapist where they will chew the food and then spit it out, okay, because they can't swallow it. But the sensation of feeling full and being able to actually chew the food is sometimes satisfying to patients, especially if they're going to be on the enteral feeding long term, okay? But you have to be careful with that. Okay, so a little bit about formulas. You won't be expected in this class to recommend an appropriate formula. Well, I did ask you that on your case study. But on the test, you won't be asked to recommend an appropriate formula. But we'll talk about the different properties of various types of formulas and why we choose the ones we choose. The first thing to know is that the content varies from 1.0 calories per milliliter up to 2, okay? So if someone had higher calorie needs, we're probably going to use the more concentrated one for that patient, okay? So instead of pumping a lot of volume into them, it would make more sense if someone has higher needs to use the higher calorie formula. So that's why we have the variance between 1 and 2 calories per milliliter. Carbohydrate is usually about 55% of calories, except in certain formulas. So in our pulmonary formulas and in our diabetic formulas, the carbohydrate content is going to be a little bit lower. Does that make sense to you? Of course, diabetic, do you remember why in pulmonary? Ventilator, right? You don't want to put the extra work of digestion, especially carbohydrates, on the patient. The fat is about 3 to 6% of total calories. It just provides the essential fatty acids so that it doesn't cause essential fatty acid deficiency. So it provides the minimum level. And protein is up to 26% of calories. So again, the higher protein formulas are going to be used for patients that have higher needs. So our patients with pressure ulcers, with non-healing wounds, are going to need the higher protein levels. One of the things that's kind of a new area of research, and it's quite debatable and controversial, is something called immunonutrition, okay? We barely touch on it in here, but if you go on to school or you go on to an internship, they'll probably touch on it a little bit more. We now know that there are certain minerals, certain amino acids, and things that are essential during healing or that are essential during metabolic stress. So sometimes our formulas will have those amino acids or those minerals added to the substance to support the patient during that process. That's what we mean by immunonutrition. So one example is that a lot of our formulas may contain glutamine because we know that glutamine helps maintain gut maintenance, okay? The thing that's so controversial about these is that when you look at some of the studies on immunonutrition, a lot of them aren't conclusive. So some will find that there are benefits from adding it, others will find that there are not benefits. A lot of times we don't know how long they should be added, so there's sometimes a lot of controversial with them. Overall, if there's been research and there doesn't seem to be any negative effects, then it's something that formulas may consider adding to their products. So again, we have to be careful when we're choosing what we call designer products for our patients because we have to know if there's a real benefit to adding vitamins. Most of them will meet the DRI, so they'll contain the necessary vitamins and minerals to be a sole source of nutrition. So things to consider when you're deciding what formula to choose is the GI function. So what I mean by this is some formulas contain a lot more fiber, some contain lower amount of fibers. How do we know what to recommend for a patient? So we want to assess their function. If you have a little older lady who's having issues with diarrhea, you're probably not going to want to give her a lot of fiber, or you may want to give her bulky fiber. So we want to look at the patient's GI function to determine what type of formula would be most appropriate for them. We do want to consider the levels of protein, fat, and carbohydrate in relation to what that patient's needs are. So whenever you go and you're doing an enteral order for a patient, you got to first calculate what their needs are. So then once you know their needs, you can find a formula or recommend a formula that appears to fit them. Caloric and protein density, that goes with that. We have to calculate those needs first. And then the ability to meet their needs. Most oftentimes, and I think it touches on this in a lecture, and Professor Scott may have touched on it, we don't want to go in and dilute a formula. Sometimes they'll make formulas and they'll dilute it or give it half strength to a patient. That's never necessary. If a person doesn't need quite as many calories, what can you do? You can give them a lower calorie formula and you can give it to them at a slower rate. There's never a need to go in and dilute a formula, because whenever you manipulate something like that, what do you increase the risk of? Contamination. Exactly. And so since this is directly going into their GI tract, we don't want to risk any additional contamination. Yes, you are. There's no reason to dilute the formulas. You can always find one that fits pretty close, just give it at a lower rate. Okay, and then there are also like specialty types of formulas. This is again like our designer formulas, those designed for patients with renal disease, those for liver disease, cardiac disease, and so forth. And it's nothing wrong with those. You just want to make sure that there's enough research and rationale to support their use. Because usually what happens, or well, I see what happens. When you have a more designer formula, what do you think happens to the cost? Goes up. So we just want to make sure it's absolutely necessary. Okay, some are, but we just want to be sure. Viscosity versus equipment. So viscosity is the thickness of the formula, okay? So you can imagine that a 2 calorie per milliliter formula is going to be thicker than a 1 calorie per milliliter formula, right? So this comes into play when we look at the size of the tube, okay? So when we think of tube sizes, they're measured in something called French, like the language, okay? And that measures the bore, or the size of the opening of the tube. And so if you have a patient that's younger or smaller, they're going to have a smaller tube size. So we just have to be careful that as the tube size goes down, when we push a very viscous or higher calorie formula through there, we have to be very careful because that tube can get clogged. Okay, so the smaller the size, the thicker the formula, it increases the risk of clogging that tube.
Okay, so it's really thick, but you have to use the small tube, small person. That's thinking, do you just make it slower? Or
You
like,
could, you would have to do a balance of the, like, maybe you're not using the 2 calorie per milliliter, but you're using like a 1.5. Okay, so a balance between that, and then making sure that you're doing flushes. We do water flushes periodically to assure that there's no clogs in there. That could totally prevent them, but we do water flushes to just kind of clear out or flush the tube. Water flushes are also important because what else might they do? Add fluid, right? So there's a little bit of fluid in the formula, but when we give water flushes, they add additional fluid to the patient.
So if we're enough to fluid, what are we increasing to?
You can if the person can tolerate it. So normal size is like a 10 French. Most adults can tolerate a 10. Some larger people may take a 12 French, okay? So a 10 French will probably accommodate most of the 1.5, 2.0 calorie per milliliter formulas. It's probably more of a choice, more of an issue when you have, think of very small, frail, elderly people, and you can't, getting a 10 French or a 12 French in some people may be very difficult. Because remember, this is going down their throat. They got to swallow this, and I have a video to show you, but this is going down their throat. So for some people, that may be an issue.
So the tolerance of the tubes depends on the size of the.
Yes. Yeah.
So does it become increasingly difficult, like say you have, like I've seen like sometimes if somebody has cardiac dysfunction, does it become increasingly difficult to make sure like you're not over flushing them because you're getting too much fluid?
Yeah. Yeah. Yeah, that's a hard one because you have to balance out their fluid needs with their calorie needs. So say they have really high calorie needs, so you want to give them a higher calorie formula, but then you have to be careful that you're not giving them too much fluid, okay? So you're going to have to give some flushes, but you want to make sure that you're not giving them too much. So those are all part of the things you have to think of. The other thing to remember is a formula can only hold so much in solution, right? So when you increase the calories, the fluid content goes down. Okay, so the more calories, the lower water content it has. The less calories, the higher water content the formula contains. Okay, questions about that? Okay. Osmolality, we kind of touched on it. The more concentrated a formula is, we want to make sure that our patient can tolerate that. So again, a 2 calorie per milliliter formula is going to have a higher osmolality than a 1 calorie per milliliter formula. So we just want to be aware of that when we're recommending formulas. Lactose, most of the formulas are lactose free. Okay, and that's important to know because if we have a patient that's allergic to lactose or can't tolerate lactose, that could be a problem. Okay, but most of the formulas are lactose free. And then you just want to be aware of the cost. As I said, the more designer, the more specialized it is, the higher the cost typically. This is kind of what we touched on earlier, and I do have a video that I'll show you real quick. But here you can see the NG and the OG tubes. Okay, so the NG tube is going to go through the nose. It's going to go through the nose here, down into the stomach. NG meaning nasogastric. Okay, the N stands for the naso, the G is the gastric where it stops. And then you have what's called an OG tube, which would actually go in through the mouth and in the stomach. Okay, so OG is orogastric. Okay. Usually, the OG tubes, we see them mostly in infants. Okay. Most adults will see the NG tube. And this is a temporary method of feeding because these tubes have to be changed ever so often because there's an increased risk of infection. Okay, you have your gastrostomy or your PEG tube, and these are both tubes that go directly into the stomach. Okay? So there's nothing up here, nothing in the nose or mouth, it's just directly into the stomach. So if you were to look at that patient, you see a little opening that goes into their stomach. The gastrostomy and PEG tube just, the difference is depending on how it's placed. The gastrostomy tube is placed surgically. So typically that patient's under anesthesia, they go in and they place the tube. The PEG tube is placed endoscopically. Okay, so when we think of endoscopically, they're going in through the esophagus and placing that tube. So the patient is what we call like maybe sedated, maybe not under full anesthesia. It's more of a quicker procedure where this would be done under full anesthesia in the operating room. This is placed endoscopically. Do you know how we have a lot of like laparoscopic surgery? This is less invasive, okay? But you still have the same result. You have the tube that feeds directly into the stomach. Okay? So then you would just connect your feeding to this portion. That's a longer term method. So if you have a patient that's going to go home on tube feeding or enteral feeding, this is more likely what they're going to have. Okay? We do have some patients that have NG tubes that will go home on those, but usually, like we see that maybe in children or in the example that you gave, and parents are taught how to place and remove that tube. Okay, so they can kind of place and remove it. And then this is an example of a jejunostomy, and the biggest difference here is that instead of going to the stomach, the tube feeds directly into the jejunum. So we would use this when a patient has either gastric or stomach issues, maybe partial or total gastrectomy. If there's delayed gastric emptying, okay, then we would feed into the jejunostomy tube or into the jejunum. Okay, so those are different places that we feed into, okay? We have NG and OG, which is usually short term, and we have the gastrostomy, the PEG, and the jejunostomy tube, which are typically longer term methods, okay? Now we're gonna talk about how we give the formulas, okay? We can give what's called a bolus formula, all right? Think of your bolus formula as the closest to the way we eat. We're not eating all, well, sometimes we're eating all day. Usually, well, I won't even say usually. Traditionally, people have breakfast, lunch, dinner, snack, or so many snacks, right? So a bolus feeding is a certain amount of formula that's given every 3 to 4 hours, every 4 to 6 hours, every 3 hours, whatever is ordered, okay? So they'll usually say, and it usually ranges somewhere between 250 and 500 milliliters. So they may say give 200 milliliters of this formula every 6 hours, okay? That's an example of a bolus feeding. They're getting it that's an example of a cyclic feeding. So they're only getting it a certain volume per hour for a certain part of the day, less than 18 hours, okay? Hmm?
When they sleep, will the food be black?
Huh?
Will the food be black?
No. It's okay for them to eat orally, they can eat through their mouth and still get the enteral feeding. It's not gonna interfere with anything.
You should ask me to give food at nighttime. Do you give reflux?
Oh.
Or
No, you can eat with the tube in. The only time you couldn't, if you had an orogastric, like a tube that's in your mouth, you could eat. But if you had a nasogastric and your GI tract is working and you're able to swallow, you can eat with the tube in.
so pumping the stuff into your stomach at nighttime doesn't make this person any more likely to have heartburn at night or like acid reflux.
Well, having a tube feeding overall increases your risk of having reflux
You mean like the sphincter open?
because the sphincter is consistently open. But what do you think we could do? Prop them up. Exactly. So when you're feeding someone enterally, whether it's at night or during the day or any time, the head of the bed should be elevated at 45-degree angle so that because that sphincter is open, we're going to just utilize gravity. If we elevate the head of the bed, we're hopefully keeping some of that down. There's always the increased risk of aspiration and reflux when you have tube feedings in general. So oftentimes when they're on tube feedings, they may also be on like GI medications, like a heartburn medication or something like that to assist with that. But eating orally doesn't increase it, it's just there. Does that make sense? Okay. Good question. Okay. So intermittent feeding. Intermittent feeding is very much like bolus, okay? You get a certain volume, 250 to 500 milliliters every so many hours, okay? The difference is bolus feedings are usually given all at once. They have a syringe, a large syringe, right? They pull the feeding into it, and they push the feeding into their tube, okay? Intermittent feedings are usually done to gravity. So you kind of see in the picture how they have the bag hanging up, and then you have the tube that can go into their stomach, so it drips into the patient through gravity. The intermittent feedings are usually done over a period of time, so maybe like 30 minutes to an hour. So if you have a patient that can't tolerate you pushing this high osmolality formula into their stomach all at once, we can give them intermittent feedings so they're getting a small volume. You're getting the same volume, but you're getting it over time. Okay, so sometimes if a patient can't tolerate bolus feedings, they would be more likely to tolerate intermittent feedings.
Okay, so the back one, I don't know, common or whatever. So for this, the bolus one, are you actually like taking it out from these giant syringe and then putting it in the giant syringe, or does it come sold like in a giant syringe?
Okay, good question. Okay, so this bag thing is old-fashioned. Okay, see this bag thing up here? That's old-fashioned, all right? This is what we call an open system, which means that the nurse has to actually like take the can, open it, and put it into the bag, all right? Whenever you manipulate something, what did we talk about? You increase the risk of what? Contamination, right? So this was what we kind of did before. Most hospital systems are going what we call a closed system, okay? So with the closed system, everything's hooked up to this pump. It's a machine. You program it. You tell it, I want to get this many milliliters every hour. That would be a continuous feeding, right? I could tell it, you can even program a bolus feeding in here if you want to. You can tell it, I want to get 300 milliliters of this every 4 hours. That would be a bolus feeding. You can program it in here. Or with a bolus feeding, you can actually draw it up yourself and give it in a syringe. It depends. Okay, you can do it either way. But of course, using this, which is a closed system, no contamination, is typically safer.
So you like, seems like you only want to buy like one pump and then just like attach like a pre-sealed like thing to
Yeah. You have this, it has a tube coming out of it, but this is a pre-sealed container.
Okay.
The tube punctures it, and then the fluid will leak out into it, but it's pre-sealed.
Okay.
Okay? You can still do it the old-fashioned way, but with the old-fashioned way, you'd have to take a can, open it, pull it in a syringe, and then give it to the patient. Most facilities have gotten away from that open method, and they use the pre-sealed containers.
Is the air concern?
They will kind of tap the tube and kind of let the first amount kind of drip out to kind of get all the air out of the tube. Yeah, good question. Yeah. Okay, so the closed system is a little bit safer. Most hospitals have gone toward that, but you can still use the open method as well for providing enteral feeding. Do you guys get the difference between bolus, continuous, cyclic, and intermittent? Those make sense? Okay. Okay, we've touched on these reminders. Never dilute formulas, right? We kind of already talked about why. Never a need to. Low-calorie formulas are available, and we can give it at a slower rate to meet the patient's needs. And then just remember with calculations, again, I know I have students that are interested in a variety of careers in here, and I just want to encourage those that are going on for nutrition. You guys are the expert in calculations, okay? So be very comfortable with doing them. And I hope that today after we go through them, you feel very comfortable with the process. A lot of times, other professionals will depend on you guys to do the calculations because we're usually the ones that are doing it all the time. Other professions are probably familiar with it, but you guys are doing it all the time. So you guys are the experts when it comes to that. With enteral feedings, there's always monitoring that needs to go on, and there are complications that we should be concerned about. And I've kind of listed some in the notes, and I'm not going to touch on all of them, but I'm just going to kind of go over some of the things you want to look at. We've talked about the viscosity in the equipment, so just making sure that that tube isn't clogged. One of the ways that we kind of prevent that is with flushing, and usually with our orders, we will indicate that the tube needs to be flushed with a certain amount of fluid, and that'll kind of help to prevent any clogging. Sometimes in the old days, they used to use Coke to kind of unclog the tubes. Have you ever poured Coke on a hard battery and gets all that acid out? Probably not something that you want to use to unclog the tubes yet with, okay? So hopefully we can prevent that with flushing, but if not, and they're unable to clog the tube, it has to be replaced, okay? GI complications. So a lot of times, tube feeding is blamed for causing diarrhea. Have anyone who works in hospitals? Tube feeding is always always blamed for being the cause of diarrhea, and sometimes it could be because remember I said if it's a very highly a formula with high osmolality, it may cause diarrhea in some patients. But sometimes it's not always the tube feeding. So before changing the tube feeding because of diarrhea, you really want to investigate a couple other different things. You want to look at if that patient's been on antibiotics for a very long time. Why does that matter? Changes the gut flora, right? So a lot of times if we've had patients that have had an infection for a long time and they've been on antibiotics, it's destroyed all the good gut bacteria, and they may experience diarrhea. And it's not because of the tube feeding formula, it's because of the gut microbiome has changed. So a lot of times with that, and I don't even know if they still do this today, but when I worked clinically, we would do yogurt flushes. So we take yogurt, mix it with water, put it in a syringe, and give it to the patient. What does yogurt have? And why did we choose that? Probiotics. Okay? I don't know if we still do that. That's been a while ago, but that's what we would do. Okay? Thank you. I've seen people kind of swatting it. So the thing about probiotics. The thing about probiotics. What did you say?
Oh, I was saying, she was looking
Oh.
What can I say?
The thing about probiotics is the reason with probiotics, there's so many specifics that haven't been identified. And so what I mean by that is, which strain are you using? What are you using it for? What is the strain? And has it been studied? So a lot of times probiotics have been looked at in research, but they maybe looked at a mix of probiotics versus the specific strains. All the strains and strains are different, and in some instances, certain strains and strains can be harmful. So that's the only reason, if you know that you're using it for a certain reason and it's been studied in that population, then it's fine. There's the research with probiotics is you got to get into the specifics. Some of the specifics just aren't there yet. That's why if they could eat orally, we'd rather them just get it from just regular food, right? All right, aspiration, we've already touched on that, right? So because their sphincter is constantly open, they're always prone to reflux. And so we kind of negate that by elevating the head of the bed about 45 degrees. One of the other things that nurses will do, nurses are awesome, they check for something called gastric residuals, okay? Residuals are anything that's left over in the stomach, all right? So here's the thing about gastric residuals. If you're feeding someone continuously, are your gastric residuals ever going to be zero? No. Okay, so that's what we need to be aware of. So we need to identify like a limit of gastric residuals when it becomes a problem. You get what I'm saying? Because there's always going to be some in the stomach. So typically what they say is that when residuals get greater than 500 milliliters, that's when we kind of want to see what's going on with the patient, okay? So are they having a lot of content left in the stomach greater than 500 mils? Are they having nausea and vomiting? Are they having diarrhea? We want to look at those things because that could be an indication that the patient is not tolerating the formula, okay? But we don't want to just look at gastric residuals. We have to look at the complications as well. If the person's having high residuals and they're having nausea and vomiting, which means it's not going down, they're throwing up everything, then we probably want to stop the tube feeding. Patients also can develop hyperglycemia for a couple different reasons. Maybe they have metabolic stress already. And what happens when you have metabolic stress? What happens to your glucose levels? They go up, right? And then we're feeding maybe a higher carbohydrate formula to them. So we just kind of want to monitor glucose levels. We have to understand that during stress, whether they're diabetic or not, they may have to be placed on a diabetic formula.
Can you repeat that?
Yes. So when people are undergoing metabolic stress, their glucose levels are going to go higher. That's just part of that phenomenon, part of that process. And so we don't want to feed a lot of glucose into their system, and we know that's just going to further increase their glucose levels. So patients that maybe they're not diabetic, they just have metabolic stress, they may end up being placed on a diabetic formula. So just kind of keep your mind, and don't get caught up in the fact that this is diabetic, so it's just for diabetic patients. Diabetic formula means lowered carb. So that can be used for patients that are going metabolic stress or other reasons why they may need lower carb, okay? Last thing I want to talk about is refeeding syndrome. What do you guys know about this?
I only know a little bit, like historically, people after they've been starving for a long time, if you feed them too quickly, all that change in the hormones and stuff floating around your blood, they end up getting really sick. But I don't get how it actually makes you.
It's as your body moves from a starved state to a fed state. It's the way the body processes potassium, phosphorus, and magnesium. There's a shift, okay? And so what actually happens is, I can't remember if you need more of those or if they shift to move inside of the cell, but in the bloodstream, all of those levels will drop low. They'll plummet, okay? Because that person's going from a starved state, not eating, to a fed state. So your first your first instinct, if you see someone who's very malnourished and hasn't eaten, is to what? Feed them as much as they want, right? Just give them food. But you can't, because if you feed them too much too quickly, The body doesn't have time to adjust from an unfed to a fed state. And all these shifts with potassium, phosphorus, and magnesium. And so the serum levels, the blood levels of those values plummet. Okay? Potassium, we know, has a very short window of normal. The range is very short. High or low levels of potassium cause heart problems, cause cardiac arrest. So patients that experience repeating syndrome, if not caught very quickly, can actually die, okay, because of those shifts. So let me tell you a story. So I was a relatively new dietitian, and had heard in school what repeating syndrome was, but never actually seen it. So I had this lady that was from a nursing home, and she was on tube feeding in the nursing home, tolerating it, doing well. But for whatever reason, the tube must have gotten clogged or twisted or whatever. So there must have been several days at the nursing home where she really wasn't receiving the feeding because the tube was messed up. So she's brought to the hospital so they can fix her tube feed, right? Remember I said if it gets clogged or twisted, you have to replace it. So they admitted her to the hospital to fix it. And so I go in because one of our procedures or policies, patients come in with tube feeding, we have to go and see them and assess them, okay? So I'm doing my assessment, writing my note, telling them patient is at risk for refeeding, refeed them slowly, and monitor potassium, phosphorus, and magnesium, okay? Well, they didn't. She came out of surgery from replacing the tube, and what do you think they did? They went back to the normal tube feeding that she was on before she left or went into surgery. And so all of her lab values, potassium, phosphorus, magnesium, plummeted. So I get this phone call, and I'm super nervous because I'm a new dietitian, right? What is this refeeding syndrome that you're talking about? What is this? What is this? So I'm explaining, to them that you can't go from an unfed to a fed state, and all these levels are going to plummet, and you have to feed her slowly, like at 50 to 60% of her needs. Monitor the levels, and then you can increase to normal. So patient ended up being okay. They went ahead and repleted those values, potassium, phosphorus, magnesium, and then they restarted the tube feeding at a lower rate. So typically we start at about 50 or 60% of their total needs, and then we gradually increase it back up to full needs. And as we're increasing it, we're supplementing potassium, phosphorus, and magnesium as needed.
So how did the reverse go?
Supplementation. So when her potassium, phosphorus, magnesium dropped, they had to give it to her IV to keep those levels normal. They stopped the feeding, give her those values IV that she needs, let things settle down, and then restart the feeding at a lower rate and gradually increase it up to normal. Yeah, and then replace them though, because it wouldn't have replaced on its own fast enough. So they had to replace them and then start over again. Okay?
How long does that take? Like an elaborate process.
For the values to drop,
Well, like to recover from.
they probably are going to try to repeat it pretty quickly. Yeah. So when they pull that lab value, because the patients are on enteral feeding, they're at least getting their lab value checked at least once, if not more, a day. So I'm assuming that that morning when they pulled it and they saw it, they immediately went to ordering IV meds to replete it, and then probably checked it again to make sure it got back to normal. But it happens very quickly. So just think about this. When you have patients that come in, that we see this in cancer patients that maybe have not eaten for a couple of weeks, okay? And they have very low BMIs, okay? So weight loss, low BMI, prolonged time without eating, those are people that are all at risk for refeeding syndrome. If we think that a patient's at risk for refeeding syndrome, we just want to make sure that we give them about 50 to 60% of their needs initially, and then we'll gradually increase it back up to normal. Okay? We also see this, we have to be careful with refeeding in patients that have anorexia nervosa. Okay? So we want to make sure that when we're working with that patient population, what if you've asked them how much they eat and they tell you a certain amount, but they're not telling you the truth? Okay? And so then you make an order or recommendation based on what they told you, but they've not really been eating that much. So then they are at risk for refeeding as well. You most often see refeeding syndrome with enteral or parenteral nutrition, but in some cases you can see it with oral as well. Okay? And the reason you most often see it with enteral and parenteral pushing a certain volume in them. With oral, they're controlling it themselves, but with intraparenteral, we're pushing a certain volume in there. We just want to remember that when we initiate patients on enteral and parenteral nutrition, we're monitoring their lab values, we're monitoring their tolerance, their residuals, their potassium, phosphorus, and magnesium if we're concerned with repeat. We just want to make sure that we're looking at all those values.